May I say hello to everyone? I am so excited to see your faces and your names. My name is Pam Hines, and I have the incredible privilege of being the chair holder for the Joanne and William Conway Chair in Nursing Research. And you are now a part of the March Conway Chair conversation. And as you know, these are meant to be lively, quite an exchange of ideas. And as always, we have people who will lead the conversation. I'm so eager for you to meet them. And then all the rest of us are the conversationalists. We have a number of standouts that I want you to be sure to know before I introduce the panel. That would be our moderator, Dr. Randy Streisand, who is on, and our Conway Scholars, Dr. Vicki Friedenberg, Dr. Lisa Ring, and I want to especially call out to you Eileen Eng, who really today is the mastermind of this particular conversation. And there's something that we have in common with Eileen and our three panelists, and that is you are about to meet incredibly creative people talking about how they have taken their clinical specialties into telehealth. And today's conversation is low risk telehealth for at risk families. So, if I may then introduce you to each one of our panelists, and you will hear the creativity in their voices when they begin speaking, and also somewhat in their background. If I may begin by introducing Canyon Hardesty, and Canyon hails today from for us from the great state of Wyoming. She also does a great deal of work for the University of Utah, and I wanted you to know a little bit more about her. She is the Director of Community Education for Wyoming Institute for Disabilities, and she's also the Director of Wyoming Telehealth Network. So it comes with extraordinary experience that spans her state and even beyond at times. She has also had the courage to go back to school. So she is in her doctoral studies right now, has a strong background in ethics, and is now looking to really further that in public health leadership. Canyon, on behalf of all of us, I welcome you. And I'd like to introduce next one of our own faculty, Dr. Natasha Shore. And I really want you to know a lot about her. She has been a clinical geneticist for over a decade and has been with us for the past 2+ years. And she's actually highly praised by Dr. Marshall Summer, who says the most amazing things about her. In addition to being a clinical geneticist in our division of genetics, she is our lead for telemedicine genetics programming. And through that programming, she has been able to set up first time appointments ever for families with us and also follow up appointments with us. And is said by Dr. Summer to be one of the most creative individuals he's ever met. So you hear the creativity now from about Eileen Eng, about Canyon, and now Dr. Shur. So now let me add to that the creative spirit of Beth Harkness. And Beth is on the line and will be speaking with us as well about her role with telehealth with a very high risk population, and that is our patients with cystic fibrosis. Beth has a very strong nursing background, and I often tease her about being a regular at the International Family Research Association's conference, where she presents every year. And it's really exciting to hear how she thinks and how she puts that into practice. Now, you know her on a day to day basis as being in our pulmonary division and as being the clinical program and research coordinator, particularly for our patients with cystic fibrosis. Welcome. I am so pleased to have the panel that we have today, and I would like to begin comments then with Canyon, please.
Wonderful. And then when I go ahead and share my screen, as you guys probably all know, I will not be able to see you. I will try to keep an eye on the comments, but please, I don't like to talk at people. So hopefully individuals will jump in here. So Pam, I appreciate the invitation. I worked with Eileen when she was a LEND student,
Mm-hmm.
which I'll talk about here in a little bit, just to frame a little bit my perspective and where I come from. So you introduced me in my role. Some of the discussion points are going to be about LEND, again, to kind of orient where I come from. We're going to talk about just overarching rural telehealth and the current use within the state of Wyoming. Some of the implementation challenges, which I'm guessing some of the other panelists will sure talk about. I did want to address some of our early childhood priorities, have a discussion about our current resources and changes in practice. I know this looks like a lot, but I just wanted to at least get individuals thinking about where I was headed. As Pam mentioned, my background is in public health and healthcare ethics. So when I sit at all of these tables, I sit from the systems level and the advocacy level versus the direct care. Although I do work with our public health offices, and during the public health emergency have been doing some direct work in that arena. So the Utah Regional LEND, again, is part of my faculty appointment at the University of Utah. And within this, we have always used, telehealth and really video conferencing to connect trainees across this 5-state region. So it's something that was really easy for us to help, switch the dial on being able to offer telehealth. But our LEND in our region looks quite a bit different than other LENDs you'll see across the nation, even in Colorado and a couple of our other states. And I believe some of the LENDs that you guys were affiliated with, it's actually more of a fellowship program where an occupational therapist will be directly linked with an occupational therapist, or somebody in social work or speech language pathology or pediatrics, spends quite a bit of time directly with that fellow. As the fellow. That's not the way it is in our Utah Regional LEND. We do serve 5 states, and it's extremely interdisciplinary. So it does, again, kind of frame how we think out west and in our very, very rural states. LEND, again, is a really interdisciplinary project that's about family-centered care, and we really embed this in clinical experiences. And I talk about LEND, again, to give you guys an idea about where my background is, but also how we've been able to utilize LEND to increase access, even for our trainees and our faculty members and our professionals connect into some expertise. So in other LEND projects, people do have the opportunity to do clinical experiences, and most of the time that had to have been in person. But with the current public health emergency, we've obviously been able to mobilize specialists throughout our region. And if you guys are familiar with us, we have very, very few specialists who live in Wyoming. Most of our families actually have to access specialty care through Montana, through Billings, Montana, through Salt Lake City, and then for Denver. So with our LEND project, as well as our telehealth project, we have really capitalized on the expertise from other states as we've been bringing specialists into our state. So I can talk a little bit more about LEND, but that's not necessarily what I'm here for, but I at least wanted to orient you guys to that interdisciplinary care perspective that my region brings to the state, and also myself as the director of the telehealth network. So the impacts on telehealth because of COVID, this group may be very, very aware of it, but I just thought I would orient individuals that there were some pretty significant, very quick exemptions that were offered. We saw quite a bit of policy and reimbursement changes in Medicare and Medicaid. Medicaid in Wyoming has always been pretty flexible and with their codes, just because of the rurality and what's needed to bring care in the state. Again, because of COVID, we saw quite a bit of licensure flexibility. I will talk about the fact that this actually proved to be a little bit of an issue in Wyoming and something we will have to consider. But because we opened up some of those licensure issues, we've seen a lot of providers from out of state actually coming into Wyoming to deliver care. And when we talk about, care and support for our high-risk kiddos, bringing care into the state from a specialty perspective is extremely important, but not at the expense of removing that community-based support, that that connection to our local community. So I think that's one thing from a rural area we've really had to consider. Hold on. here. So some other issues, as you guys know, expanded use of virtual platforms and some of the CARES funding. So this wonderful provider is named Carrie Ann Duncan. She's a physical therapist and actually has recently moved to Wyoming from Texas and has had quite a successful transition to telehealth. She moved here in November and transitioned her services with the support of actually the LEND program in February, and has really been doing telehealth for the purposes of parent coaching, and has really seen some pretty significant improvements in kiddos, also because of the engagement she's able to have with her families and with her providers. The statistics on the left-hand side really just highlight the fact that we have significant healthcare shortages in the state of Wyoming. So telehealth is a good fit, however, really needs to be considered in the whole scheme of direct services. So in our telehealth network, we have about 2,500 providers who we actively support, who are either delivering direct care or direct group support. This represents about a third of the entire state, the providers that are actually doing telehealth. So that's about 5,000 providers in our state who are actively involved in the delivery of healthcare, right? And this is not just direct care, it's also group support and health education. Here's just some additional statistics about what we've seen. This actually grew exponentially about 400% over March and April, just to see the providers going from, and this includes Medicaid claims data, and some other pieces I could talk about, but there was a significant shift. And in Wyoming, the transition actually was a little easier, I think, as I've been working with other states and other providers, just because people were semi-used to using different distance modalities. So when we look at our specialties by our providers by specialty, and these are the from March of 2020 to January of 2021, we see about 31% of our overall users of telehealth in Wyoming are mental health. I think there's a lot of reasons why that happens. I think, there's, it's been a field, as many individuals on the line may know, that actually has competencies that have been developed for their providers and have really been thinking about this and how to deliver this care remotely. Our family practice, we used to have about 30% of our users in the state who were delivering care with a background in family practice, and so that we've definitely seen an increase there. We've seen an increase in our public health work. Our public health facilities in the state of Wyoming really serve as a community health center. So we have several. We actually have 8 patient-centered medical homes, but our public health nursing offices in state, we have 30 counties and about 45 public health offices end up serving as the hub for our health. So when we talk about telehealth, our public health offices have been a place that our communities are going into those offices and connecting to specialists. Again, we're seeing physical therapy, speech language pathology, and then here are some other high utilizers. I think some of the success that we have seen is, again, that rapid transition. We had at the University of Wyoming and our College of Health Sciences have been supporting work, obviously through LEND for telehealth and also in our practicum programs for about 5 years. I've been there for about 7 years, but we've been doing this work. So it was a pretty easy way for us to do that because we were already connected statewide into a system. We're able to access very quickly CARES Act dollars that enabled private providers, small facilities, and our critical access hospitals to get the technology they needed right away versus waiting for some of that reimbursement care. And again, I know that not a whole lot of states have this statewide approach or this hospital-wide approach, but this is something I definitely think, contributed to the success we've seen around our region. Some of the main things, of course, that we're seeing with telehealth and some of our evaluation, of course, is decreased travel time, this increased acceptance by providers, which actually goes a little bit against some of the literature we're discussing. I think when we're specifically talking about high-risk kiddos, we've really seen increased engagement by families to be involved in the care and to do some advocacy specifically related to some of our physical therapy services. But I would question, or I would put it out to this group really to think about how families can be utilized in a different way and supported in a different way using telehealth. We have some early childhood priorities. I thought I would list them. We've been doing quite a bit of needs assessments across the 5-state region, actually, because of LEND, and these are some things we'll really be focusing on here in the next couple of months. This is Pete Gosar and his wife, Dr. Grace Gosar, run a not-for-profit clinic in one of our communities around the state. And I think, as most of you probably have experiences, that telehealth is great and it's good for some things, but it's not good for everything. So I think that's important to consider. And of course, this access to the actual equipment sometimes produces barriers, right? Internet. We have a very rural state, as I mentioned before. You know, our cities have access to broadband, but our local communities do not. And sometimes we see our most at-risk families are living in our really rural communities. So that really needs to be a consideration. And of course, this lack of familiarity with technology. Not everyone has smartphones. Not everybody feels comfortable with this environment, even though we've been living it for the last year. I want to briefly go over just some of our current research initiatives. We've been doing very quickly, because we had so many mental health providers within the network and across the region, started to do some research around mental health. What that looked like for just implementation, knowledge, satisfaction, additional competencies. As I mentioned, mental health is one of the only fields that actually has telehealth competencies. So we've been doing some evaluation on that. And additionally, what are the practice changes, right? Are they seeing more or less of certain kind of patients as a result of this? Additionally, we've been engaged in a longitudinal study. We have about 50 providers who are actually participating in this longitudinal study that we're running for 30 days. Providers have to complete this telehealth encounter experience. Again, it's very interdisciplinary, and the focus is looking at the type of visit. So getting an idea of what people are being seen for, their perceived success. And then, of course, the thing that everybody wants to know is about the cost and the increased outcomes. We've got a couple of other surveys in development and some research studies that are in development, but I think I'll leave it at that and just discuss a little bit more of the barriers, right? We're seeing a lot of survey fatigue. We have a significant problem in our region and in the state for getting access to administrative and claims data. So I think when you're thinking about a lot of this cost and outcomes data, hopefully within your system, that's not as much of a barrier, but it has been for us. And then we're really struggling with some real clear research mandates from the statewide perspective. So I think that is about it that I have. Hopefully it provides you a perspective on what it looks like in our rural communities, what it specifically looks like as far as interdisciplinary care and some of the opportunities and challenges we've experienced in our region as we've thought about just increasing access and keeping that quality of care while delivering it virtually here in the state of Wyoming.
Many thanks, Canyon. That is the perfect beginning of the panel conversations, and I'd like to continue the conversation with Dr. Shur.
Thank you so much. So I'm away right now for a couple of weeks, not for a couple of weeks, just for the week. So I'm very sorry. I actually had a few slides, but the internet here is a little bit in and out, but I would love to talk about what I was going to say. And then, of course, I'm very grateful to Eileen and to all of you for having me. What I wanted to review was a little bit about our program, and then I really enjoyed hearing about the multidisciplinary and the amazing way that you've put your program together. So what I'd like to share is kind of our 3-year division-wide odyssey to improve choices for patients with rare disease and try to increase access to, with just a few short examples of some of the positives. But kind of after this honeymoon period, we've also noticed some real challenges, and we're trying to think of creative solutions. And so what I thought I would do after just a few minutes of talking about our experience is turn to this amazing panel and name where we are in our greatest challenges and see if you have sort of ideas or share those same concerns. So in terms of our division-wide story, over 3 years ago with NIMAC and HRSA, we started a pilot program prior to COVID of rare disease patients. And it was at first really challenging to get people to try it. That was our biggest difficulty. And so we had only tried maybe 200 patients, and we were trying different platforms. They were all very, very difficult. But when people would actually try it and join, there were these beautiful moments. So an example would be a mother who herself had Fragile X. She had a test result. She didn't realize when she had the result what it meant. Had a twin sister. She only had a lot of anxiety and had several children aged 18 months to 14 with autism, developmental delays, and a few healthy children. So she had with her partner 6 children total. 4 had all of these difficulties, had a test without knowing what it means several years prior, and then had a lot of transportation and other issues, was in an underserved community. She happened to be African-American. Anyway, she had never gotten care. And so in one visit, we were able to look at her report, explain that she had Fragile X. I set up visits because she had issues and got all the other children tested. So it was huge in terms of resources. And that was kind of one of my first. Oh, sorry. Did somebody have I thought I heard any.
You've muted yourself.
Sorry. So that was one of my first. I'm sorry, the host is muting me. Sorry, it's not me. Oh, can you hear me now? Sorry, it was an accident. I think that the host accidentally. Anyway, so then sort of many of these incredible moments were happening. You know, a mom who had missed 3 appointments because, again, another mom, not the mom who had Fragile X, and we helped her with services, everything, but another mom who had a known familial seizure disorder, but hadn't been able to test, had a baby born with seizures, another child at home with seizures. She was so good in the hospital. I couldn't understand why she missed 2 appointments with me in person. Then I called, offered her telemedicine. It turned to be, again, a transportation issue. We were able to confirm the testing, test the new baby, get that information to neurology. They kind of changed some of the medications. So that was sort of a second aha moment. These were sort of my first moments 3 years ago. And so we started to expand the program. We realized that for children with autism, for children that we couldn't get good visits on, and we couldn't get them to kind of interact as much in clinic because they were scared, all of a sudden we were getting them to climb upstairs and rule out muscular dystrophy. And so when COVID hit, we went from this 200-person pilot where it seemed like we were getting really interesting stories. A lot of patients were telling us that they wanted more of this, to within 1 week converting our entire division to telehealth first model. And we published this in the American Journal of Medical Genetics, where people would be screened by telemedicine. We trained everybody in our division, 13 geneticists, 13 genetic counselors, 2 dietitians within 2 days over the weekend. We did a train one, have them train the other person model. And within 3 business days, and then if anybody needed to be seen in person, Dr. Summer and Dr. Regier, or whoever was on call, would see them in person, as the, you know, unless they were in the hospital, then the on-call attending. But Dr. Summer and Dr. Regier decided that they would have us kind of be the telehealth first screen. They're really heroes. Anyway, so we did this system, and it actually surprisingly functioned. And we were amazed because from that first visit, we could glean really what they needed. Do they need an organized second visit? It was just We had daily meetings. We helped each other get people on. We figured out the translation barriers. And it wasn't perfect, but it did allow us to maintain access in a time when many patients were hesitant to come to the hospital. So now we've had this amazing surge where we went from only 200 visits to everybody in our division offering telemedicine with, over 8,000 telemedicine visits or more done. But now we're recognizing the limitations and trying to get past them. So it's an amazing, there have been so many amazing personal stories and so many times where it's worked. But in terms of those limitations and what I think would be great to discuss as a group, number one, we are seeing that a lot of families with language barriers have more trouble getting on. That visit is more disjointed than even in person. Those are already challenging visits. So we're debating, do we just see patients with all these language barriers in person, or do we offer, and we're trying to pilot, our next stage will be to pilot mobile carts in clinics that have a stethoscope, that have other things, and work with the clinics. That's what we're trying to organize now, so that the clinics have somebody on site, like the local pediatric clinic, who helps patients come on to their specialty visit. So that's one huge limitation. The second limitation is that we've had a lot of families who kind of misunderstand the idea of the visit, and they're picking up school lunches, doing this in their car, don't have a quiet place. But at the same time, they don't have time, they don't have childcare to come in. So what do we offer for those families? Is there sort of a quiet area or a place that they can turn where they can get a meal and telemedicine? What do we do for those families? And then the third huge barrier, and we're working with the American Public Health Screening Laboratories and coming up with a protocol, is the lab piece. So we've sent a lot of swab kits. We're getting more and more genetic testing out that way, but sometimes figuring out, we do the telemedicine visit, we know what labs, but trying to coordinate kind of with them their next steps has also been very hard. And fourth of all, the fourth major limitation is we don't really have the data to understand which patients truly benefit the most. So is it our decision because it's just easier for us? Is it their decision because it's easier for them? Or is it within the medical interests, and what are the protocols? And then of course, the final barrier is the physical exam piece, which we're working on. We're working on new models. We're working on, do we send patients scales? Do we send them telemedicine kits with tape measures? Do we have them do pictures in advance of the visit? We're trying all these different things, but those are the things. And I would love to, if all of you are willing to kind of hear about those, and if you have other limitations, but those are kind of top 5 that we're working on right now.
Nicely summarized. Great 5 points made. Thank you for that. And now let's go to Beth Harkness.
Beth, we can see your screen, but we can't hear you yet.
Would she have been muted, Eileen?
Thank you. It looks like Eileen just unmuted me.
Good.
Okay, great. I'm glad you can hear me. Thank you. I'll start again. So I'm Beth Harkness. I'm the Cystic Fibrosis Coordinator at Children's. As Dr. Hines so kindly introduced me, I would also like to tell you that I'm representing as part of a team in the Cystic Fibrosis Division. For this component, I'd like to tell you how we implemented telehealth, integrated that into the cystic fibrosis care model during the pandemic. Just a brief background. In cystic fibrosis, these patients require an incredible amount of care. There are cystic fibrosis guidelines set out by the CF Foundation that CF patients, even if they're perfectly healthy and feeling great, they are to come in every 3 months at a minimum. Now, many of them we see much more frequently, and some weekly, biweekly, monthly. So it's a very high demanding population with a lot of needs. And when the pandemic hit with the shelter in place orders, we had to quickly figure out how we were going to maintain this quality care for that population. And I heard Dr. Shore say that they started with 200 patients, which I think is very impressive because we have 200 cystic fibrosis patients. And let me tell you, it was hard. So at all ages, we run a pediatric and adult, and we also see prenatal and rule out diagnoses. So some of those come to us weekly. Primarily those patients that have concerns for cystic fibrosis actually come through me and my clinic rather than to genetics. We reach out to genetics if support is needed, but that's one that's been carved out of genetics. But I look forward to partnering with you a little bit more, Dr. Shore, to find out your approaches here. I'd like to tell you about the fantastic team that I mentioned before. We have a social worker who is Carol Chase, who's been with Children's for some time now, and she's incredible. And Carol was actually the first person to get certified to do telemedicine in our division. And we had been trying to drag others along for about 4 years without success. And so she was really integral in taking off on this platform, being the first that was prepared. Dr. Lawless is our psychologist for the cystic fibrosis population as well as in our pulmonary division. And she had incredible organizational skills that enabled us to work through a lot of our processes. And she had specific licensure as well as Carol. Each multidisciplinary specialty had their own licensure, hills to climb per se. And then Erin Canning is our research assistant in the cystic fibrosis program, but she also supports pulmonary. And when Erin came on board less than a year ago, she really came under fire pretty quickly because not only was she learning her new job, but she had to very quickly adapt and work with all of the research clinical trials that we were involved in nationally and internationally to figure out what we were going to do to adapt to be able to continue these studies. So as I said, the pandemic hit March 13th, 2020, and everything changed. And I'll get to this a little bit later, but we were already part of our own formed team doing quality improvement and process improvement, but this was nowhere on our radar at that time. So as COVID hit, we were struggling to find out how were we going to continue to provide these services. With the cystic fibrosis population, infection control is the number one concern without a pandemic. So with the pandemic, it became even more complicated. Our team quickly started addressing each individual issue and performing PDSA cycles to tackle each micro component that we were facing to get this off the ground. So although Carol was, as I mentioned, certified and got her licensures, no one else had, and they had to do that. But even the platforms changed because though we had Zoom, everybody knows it wasn't Zoom with HIPAA per se, meaning that we had to get a Zoom for healthcare put into place. We had to, as the whole hospital did, develop consenting processes and how are we going to schedule these? So this just wasn't a provider issue. This went across the board. We had to find out the insurance, who was participating, who wasn't, and as you know, that was just a moving target. And then we had to be able to communicate with these patients, see if they could qualify and get them online and really cement the interstate licensure agreements and then initiate the calls. So that was really difficult during that time period. But as Dr. Shore mentioned, we had to do this immediately, like yesterday. So our patients still had problems that we had to address, and we had to be able to do this within the regulations that protected the staff as well as the patients. So as we move forward, developing these processes to evaluate how we were going to implement them, we had to also then make sure once we were talking to them and that they were off the ground, that we knew we were doing a good job and we were meeting their needs. And so we developed some surveys, and that was in collaboration with other CF programs. And then we had to get our surveys translated, as you know. We had to go through IRB approval, send them out in REDCap, and get that data back to us. And through that process, each step of the way, there were changes made to meet the patient needs. So these rapid cycle PDSA I was mentioning just gave you a little background, the problem, our intervention, how we met with different levels, who was needed at those time periods, and the actions that followed. So this is a great deal of detail, but I just want to sum it up to show you that this is what it took just to get going. And then as we went on, we had to not just include the physician because that was the primary person to get off the ground, then we had to include every multidisciplinary team member in the cystic fibrosis program, and there are several. As I mentioned, we have the social worker, the psychologist, the research assistant. We also have a dietitian. We have physical therapists, and it branches out from there. And also the nursing staff help. So we got all of them on board, and that was always difficult when we were seeing them in the clinic because you could have, easily 6 to 8 people that need to cycle through a room. So it was never easy to begin with when we were all in person, and now we were all in separate locations with varying challenges to the electronic connections that we had. But it worked out. So once we got that all set up, we've been working on a sustainability plan, and we've also been contributing to that plan through the Cystic Fibrosis Foundation. And as you've probably experienced, many of the state licensure certifications that they offered previously were starting to become revoked, meaning that now the temporary interstate licensure agreements have now expired. And so where we could have a psychologist or even a physician be able to cross certain lines, now we have to reel that back in and then quickly readjust and respond to the climate that they're giving us. We are working on trying to further this to make it part of the complete ongoing sustainability plan for the CF population. So instead of requiring every visit to be in person, could this potentially be a 50-50 model, 50% telemedicine, 50% in person, depending on the patient needs? Since we're all working in a silo, we're trying to break down those barriers and speak to different centers and speak to the foundation. We're very fortunate in cystic fibrosis that we're really, really well connected through the CF Foundation and the services that they offer. And the patients are as well. So they're getting real-time information that we have to be prepared to respond to very quickly because they'll hear somebody's doing it and they're like, oh no, we better get to that now. So, and as well as what we're doing in our own program, we have to address the greater needs of how we sustain this from a leadership perspective throughout the institution. So as we mentioned, maximizing patient satisfaction and access was our first goals, and that is really some of the most important, but our accounting friends may tell you differently. So, there is the push to, maximize revenue and business volume. So we have to keep that in mind and watch the reimbursement. But we did notice, we're very fortunate that our improved care team process did improve. We were able to get more people on a call in a shorter amount of time and improve staff and patient satisfaction. So we were pleased about that. So we're just working on this middle part here to see what leadership will do with that. So as I mentioned, the problems that we had to deal with, I put these in cogs because really they all went hand in hand. When you go to the length of the visit, space constraints, like, oh, telemedicine's really our answer, but not all of that comes into play. Because as I think it was Dr. Shore mentioned, access is an issue for patients who are not connected. But on the other side, you have the no-show rate that's greatly decreased. So again, we're raising volume here, lowering volume there. Dealing with our systems of care and infection control, that was really helpful because now patients aren't being exposed every time they come into the hospital and clinic. And again, won't go into that too much more for the revenue and expense cycle, but we have to take that into consideration as well as the patient and staff satisfaction. We did sort of a category type approach to who would be eligible to be seen in person or who would be okay to see over telemedicine depending on their current issues. So we took that into account each time we're scheduling somebody. We really want to prepare our patients well, so we try and give them the things that they should know and the things that they should have. So if we're going to be successful, it requires pre-work not only for the team, but also for the patients. They should come with their list of what they need to have accomplished at that visit, refills, pharmacies, primary concerns, changes since last visit. And if we're going to do a physical exam over the phone or over the computer, we want to be able to see things and have that data. Weight is a gigantic issue in cystic fibrosis. So it's like, and we have the advantage of saying, oh, well, if you have a scale there, go get them on the scale instead of just asking the weight. So good and bad of everything. We can hear them cough, which gives us an indication, but we can't listen to them with a stethoscope. This goes into a great more detail about the visit itself. And in response to not being able to see the patients in person, but we need all of this testing, as others were mentioning, what we instituted was setting up a diagnostic visit, meaning one day we're going to bang out all of this in 4 hours. So it was a lot of collaboration and scheduling to get the patients in so we'd have this data, but it worked out pretty well. And most patients were willing to come in to do that, knowing it was limited exposure and health shutdown really children's was. It was very protected. So we were fortunate there. So we went on to do, as I said, our IRB, and we've been writing up our methods and designs for studying this. It's in for the IRB. We're just continuing to do the red cap. We did discover through our surveys that, as I mentioned, our visit collaboration increased greatly with all of our multidisciplinary team measures, as well as the whole team agreed it was better, and the patients, because instead of what could be a 3 or 4 hour regular visit, turned into 45 minutes or an hour at max. So there's a lot of benefit there. And then our further discussion goes on for our quality improvement. I'd like to take a moment and just have you hear from Carol Chase first as our social worker, and she can tell you some more about our program.
Thanks, Beth. We just really wanted all of you to be aware that we couldn't do this alone. We do have a team through the Cystic Fibrosis Foundation, which is over in Bethesda. We were already participating in a transplant consortium model where they connected care centers to the nearest transplant center to improve relational coordination and communication between the two teams supporting patients and families. And what we found was during COVID, this was the perfect time. Everybody just needed to transition over to that telehealth model. So we were already working with a coach that was working with us not only through the CF Foundation, but also the Dartmouth Institute up in New Hampshire. And with that group and working with our local transplant centers, there were several different consortiums across the country. So we really benefited from hearing what other centers were doing across the country. And if I can just sort of put in a plug, I know Dr. Shur was speaking, some of her challenges were the non-English speakers. the telehealth access and the lab work. And those three things were really a struggle for us also. There are some in our community who still do not have access to the internet. And so actually what we pivoted in doing with some of those families is they actually tag us on their children's tablet that came from their public school system. So somehow families know how to use that tablet for school. They just can't figure out their phones, and it worked out. So that was one of our solutions that's worked out closely at this point. Our language challenges, we are benefiting from our interpreters in the hospital. As Beth pointed out, it is kind of clunky, but it does work. And then, of course, Beth came up with the great diagnostic visit criteria. The other thing that the foundation is doing with us is that they have put together a free spirometry program for any patient or family who is interested in doing that. So we provide them with names and contacts, and they will ship spirometers out to these families to do pulmonary function. So we are sort of working it through. The other thing I wanted to give a shout out is I've been trying to set up a family and patient support group for years with this populace, and have found that folks, really after working all day and the childcare issue, they just don't want to come back in. And telehealth has been amazing. So I have connected with our local DC chapter of CFF, and we're doing an English speaking group on Tuesday nights, and we're doing a Spanish speaking group on a Thursday night. And this really came about again through the telehealth work. We were just finding that families were so anxious and worried. We couldn't spend the time with each of our appointments that they needed. So we really shifted that method to telehealth. I'll also say Dr. Lawless has done an amazing job in picking up a lot of individual patients that have now reached out to her during this pandemic, and again, seeing a lot more consistency in our interactions with families rather than missed clinic appointments.
Carol and Beth, thank you both so much. And now let's have just a few moments to ask the panelists if they would like to comment to each other, and then let's open it up for all conversationalists.
Pam, would it be okay if I just, this is Beth, I'm sorry, just give Erin a moment just to briefly speak on the research aspect and connecting with patients? Is there enough time?
I think we've got about 2 minutes. That would be great. Thank you.
Okay, thank you. I appreciate it.
Yeah, I'll try to keep it, I'm Erin. I'll try to keep it as brief as possible on the research side. So obviously, when the pandemic first hit, our trials that weren't phase 2 or higher risk trials all took a pause, and they're actually just now starting to reopen. And one of them actually has implemented, as Carol mentioned, a home PFT. It's called a Zephyrex. So that allows us to assess their lung capacity at home. This study is kind of implementing it just to see how effective it is. So we're interested to see the results of that, but these home PFTs hopefully will yield very nice results in allowing our patients to be assessed from home, instead of coming in to see how they're doing. So we're working with that. One of the big challenges that has been faced, though, is with the IRBs, especially doing remote consenting. One of our studies requires us to consent quite often. We kind of blanket consent everyone because it's just a patient database, the Cystic Fibrosis Registry. So we're still working with the IRB to try to get approved to do Zoom telehealth consenting. That's been moving slower than expected, but we're hopeful that with the further implementation of telehealth, that these teleconsents may become much easier for the patients to do as well as for us to do. And then moving forward with studies, we're seeing some decentralized trials coming in using home healthcare components. So hopefully for the future, again, that just hopefully makes it much easier for patients that want to enroll instead of coming into the clinic for 5 times within a 2-month period. Hopefully some of these can be subbed out for home visits. So quite exciting for the future, and we hope that telehealth continues forward.
Beautifully summarized, Erin, and very, very exciting. Thank you for that. So now we could go to the panelists who may want to speak with each other, and then we'll open it right up to all conversationalists, and Randy Streisand will be helping us to moderate. So panelists, comments for each other or questions?
I have we're waiting for the panelists to each speak. Sorry. Okay.
Oh, Randy, go right ahead.
Okay. I just wanted to say I appreciated everyone's sharing about how these different pediatric populations have all been able to be reached through this really challenging time. And I also am optimistic, like I've heard from each of the groups, that this will continue in some ways post pandemic. I wanted to just comment as a psychologist on Canyon's presentation, where she shared that a large number of the telehealth visits through Lend were for mental health. And 2 things, we also had a few providers doing telehealth before the pandemic, but had to quickly pivot and all learn. But many of the services we provide are weekly. So one time intake, yes, they might have to travel 2 hours or an hour to come, or even a half hour. But for those kids who we're trying to see every week for therapy, it's really just so ideal to be able to do that and be much less disruptive, not only to the child and school, but the whole family, babysitting, work, all of that. So even though we are up and running in terms of being able to see people in person, and we encourage them because we have moved offsite to a new building, it's really hard to get families to come. Like, once they are, still a little anxious about COVID, but they also realize, well, if I can do this from my home, I'd rather do that than come in. So we're seeing that as a challenge, and we're working on the licensure issue. There's some legislation right now that's trying to make it easier so that post-pandemic we won't have to apply for all these exceptions like people have had to do right now. So I know we have a few other psychologists on this call if anyone wants to speak up. I know Shayna Coburn is here and Erin Sadler, and there could be others, but that's who I noticed. But I think mental health, it's really huge. It's not for everybody. Like a first visit, if somebody is suicidal or really at risk, it's hard to do that. And you just sometimes don't know. So in an ideal world, we would see people in person first, but this isn't an ideal world. It's far from it. And so we're doing, we're doing the best that we can at this point.
Thank you, Randy.
I have a quick question for that. And I think I talked about the fact that we don't have school-based health centers here in Wyoming, but we do have really active public health and school nurses. But I just wondered, when you talked about kind of those weekly visits, do you deliver them or in schools if that is, or will you deliver them in schools as your schools go maybe back to in person?
We would be open to doing that as long as the child's can be in a place that's confidential. They can't be in their classroom with everybody around. But if it's something where they can go into a separate room and have their device, then absolutely we could do that. Yeah, it's actually worked with most of the kids here are not in person, and it's worked to be able to offer services in the middle of the day for some form break, or even Wednesdays has been, and Mondays, depending on what school district, has been an asynchronous day. And so we've been able to see people at different times then too.
Canyon, this is Eileen.
Yep.
Can you share a little bit about the experience in terms of the shift, the paradigm shift for how parents engaged? You mentioned like the visit with the physical therapist, where there was a passive acceptance previously when they were on site, but that there have been some gains made. What would be the research question that would show value added? If I can just kind of pose that.
Well, that's a really hard question. Randy, do you want to go ahead? I think it's hard, right?
Well, can you let me make it easier. Can you share a little bit about what the physical therapists are seeing when they're in the home and directing the parent that we talked about?
Yeah. So Carrie Ann, who I posted the quote from, has really seen, obviously the parent has to be actively involved, because her as a physical therapist can't actually be showing and teaching and moving, although there are some concerns there, right? But given that the parent has to be actively involved, she has seen. And again, maybe the research question is effectiveness and outcomes and speed of those outcomes associated with the the kiddo who's receiving that care, but has seen parents who do feel more confident, who are actually calling her less, because even based off of our reimbursement schedule, we are only allowed to see within physical therapy 20 visits. And so she's actually seen a little bit of a shift in kind of the frequency that's needed. But Eileen, you're exactly right. I mean, we need to get at outcomes. We need to get at, cost effectiveness. We need to get at, especially for, our population's patient-centered care. So that's a great question.
Kathy.
So I have a comment, and then I have a question for Dr. Shore. I feel a paradigm shift coming, and it's going to be really interesting to see how our healthcare works after this pandemic is over, because of listening and hearing about, increased satisfaction with home visits and perhaps increased efficacy. So it'll be really interesting to see. But for you, Dr. Shore, when you're talking about, the inability to actually do certain kinds of physical exams, I have this vision of either a home health nurse or an activity, or a therapist being there who could be your eyes and ears. And certainly I think there are stethoscopes now to do over the internet, but I was just wondering if you had engaged home-based therapists or providers in those exams.
Yeah, not yet. I think that's a great idea, but we can do so much of it. I would say 90% from really good pictures of the face, the side, the hands, the feet, the growth curves. To me, growth curves, I always teach the medical students, even before I see a patient, are so instrumental and tell you such a huge story. So just those things. But for me, there's something about sometimes just wanting to jump through the screen and pick up the baby to measure the tone. And it's not, I know somebody else could do it. And I know they've had neurology visits. And so that's where I think the data will come in, because I don't know if that's just for my emotional, I need to pick up this baby and at some point meet this baby, that especially if it's not a simple thing, and actually see them walk, or maybe the skin exam. I've caught strange skin things that people forgot to tell me, or even kept spots on parents or things. And yes, you can try to have the pictures head to toe, but you're still going to miss something that they may have been seen by 10 providers, but maybe you should have caught it. And that I do have anxiety that I'm letting that part go. So how to balance it? I feel like at some point, to be a better doctor, I do want to go back, and I do see people in person still, obviously, but I do want to go back to, okay, maybe on the checklist at some point, I do need to meet this person.
I agree.
And pick them up until I can jump through a screen, or they can jump back.
Thank you.
May I thank every one of you. We've reached the end of our hour. Darn. But I have special thanks for all of our panelists and all of our conversationalists. And we look forward to welcoming you back to the April Conway Chair Conversation, the first Tuesday in April at 12:30. See you then. Please take the best care of you and each other. Bye now.
Thank you.
Bye-bye.
Thank you, Dr. Shore, Canyon, and Beth.
Yeah, I just wanted to say thank you again. Eileen, you're amazing. Thank you for inviting me. That was
yeah, it was terrific. Thank you.
Thank you. That was really nice. It's amazing to hear.
And I hope your vacation continues, but I think lots more We'd have 2 hours. Yeah. Take care all.
You too. Bye-bye.